Welcome to the Physician Associate Podcast.
Hello, welcome to this episode of the Physician Associate Podcast, and I'd like to wish everybody a very happy PA week. I'm delighted today to be joined by Professor Jim Parle. Jim, welcome to the show.
Thank you.
Throughout making this podcast, I've spoken to a few different people about physician associates and how the profession was created in the UK, including Professor Phil Begg about the history of the profession, Jeannie Watkins, Jade Moore, all these names that are now sort of really involved in running the profession. And time again, your name has cropped up as somebody of key importance in the development of the PA profession in the UK. So thanks so much for coming to talk to us.
You're welcome.
Would you like to start the story? Where did you first come across physician associates? Where did you first hear about it?
Yeah, I will. It's about 20 years ago. What happened was, at the time, I was leading the medical education team out Birmingham. So basically running the medical student course there. And I was approached by Rachel DiToro, who's now Rachel Catanzaro, who was in fact, I think she was the very first American PA to work in the UK as a PA. And she came to see me with a colleague, trying to see whether I'd be interested in supporting the introduction of a PA program. So I said, well, what's a PA? Because I'd never heard of them. And she and her colleague explained, and I am ashamed to admit that I actually said, nah, I don't really think that's going to work. And Rachel and her colleague went away with their tails between their legs. So that was a bit uncomfortable looking back. But it certainly sowed a seed, because the next thing that happened was a guy called Bill Fenn, who's a name that pops up quite a lot in the literature. He's an American PA, and he was over in the UK in the early 2000s, or the early noughties, whatever you call them. And he came to see me at Birmingham to talk about PAs. And he was very persuasive. We sat and had lunch together. And I would say by the end of that, the seed that had been sown had, stuck roots down and got a few leaves, and was definitely, my metaphor's going a bit wobbly now, isn't it? As definitely well established. And then I became more and more involved.
Excellent, thank you. And listeners to the podcast can find an episode with Rachel DiToro called The First PA in the UK and listen back to her experiences as well as being the first PA to come over and work here. What was the impression amongst colleagues and yourself at that time of PAs? Was there much understanding at all?
Well, I would say the wider medical education community as such wasn't particularly aware of this idea, recognising that the PA role worked, and it worked very well. And really, we only needed to modify it a little. I would call it a left-hand drive to right-hand drive conversion, another metaphor to fit our circumstances and driving on the other side of the road. That metaphor will probably crash and burn shortly.
I like it. I like the metaphor. Okay. Can you remember what it was was there a light bulb moment where you started to see the benefit, or was there something that somebody explained it to you?
Well, it was the meeting with Bill Fenn, really. I mean, he's a very senior American PA. He's retired now, but he'd done some work with the Royal College of Physicians, who were also quite open to the idea. They published some stuff on it, and there was a kind of an atmosphere around in the NHS, at least, of we need to think hard about what we should be doing. And he knew so much about the profession, and particularly about the early part of the profession, because although we think of the profession being very well established in the US, which it is, of course, it's not been around forever. So there are people who remember, Bill wasn't one of the very first, of course, but remember the relatively early days. So we had a lot to learn from them, but he was also, we can't just repeat what they did over there. We need to develop and modify it.
Actually, as it is PA week, it might be worth just touching on that history of the profession that came out of the States. As I understand it, it was in the 60s, after the Vietnam War. There were lots of field medics with lots of skills that had been used in the war, came back to America looking for work.
Correct.
And then Duke University? Duke,
I think they call it
Duke hoovered up these experienced field medics and created the physician assistant beginnings as we know it now.
Yes, that's absolutely correct. One of the interesting things about that, they had a severe shortage of medics, particularly in primary care. Nothing new there. And they had these people in large numbers, some tens of thousands of people coming back from Vietnam. And we tend to think those of us, and I've never been in the forces, but most of us who've not, we think that medics, by which we mean what the army means by medics, deal with battlefield injuries and shrapnel and all this kind of stuff, which of course they do. But they also do a lot of musculoskeletal stuff. They do mental health. They do drugs and alcohol. They have a much broader palette. So it isn't just that they know how to resuscitate somebody on the battlefield. They know a lot more than that. Obviously, they needed a much broader training. The idea at Duke University was we don't need to start from a blank sheet with these guys. They've got a lot of experience and a lot of maturity and are used to making decisions. And so they're a good substrate, if you like, to develop quickly into a new profession, which I thought was a very valid approach, which is one reason, I guess, why the American PA professions are courses, I should say, almost exclusively, if not exclusively, postgraduate entry. Because what you're looking for, I think, and I think we should stick with this in the UK myself, is you're looking for, if you like, proper grown-ups who are mature thinkers and preferably have got some experience outside of universities. I'm sorry, I've diverted really away from the beginnings of the profession in the US to recruitment in the UK. But that's a good example, I think, actually, of us modelling on the US, but not necessarily quite copying what the US does.
So as things began to grow in your patch, what was needed to set up a course in PA studies? How did that all come about? What were the beginnings of it in Birmingham?
I had become a convert, if you like, and Nick Ross, who was the educational support person at Birmingham in the medical school, and we'd both been there quite a while, so we were well established, but willing to try something new and take a risk, if you like. So that was what it was. It was the background context, local support, and a couple of risk takers, which is basically Nick and I. Of course, the real risk takers were not ourselves or the university. They were the individuals who particularly came onto the very early courses. We opened in January 2008 with people like Kate Stroughton, or Kate Lamb as she was then. And, these are the people who are giving up their current profession or whatever they were doing for something that nobody had even heard of. It was just an amazing risk to take. So risk takers was probably the most important criterion, actually, although how you define risk takers is not necessarily easy.
Yeah, it must have been incredibly difficult decision for those PA students to want to do this, knowing Absolutely. That there might not be a profession 5 years later.
And I would say 3 weeks in, they called us, called myself, and David Coons had joined us by then. They called us. They didn't. That's putting it too strongly, but they were very keen to have a meeting with us, and they wanted to know, when's this profession going to be regulated? That was the real thing they wanted to talk about. This would be like early February 2008. What's that? 13 years ago and a bit. And I said, well, we're working on it. We're doing our best. And here we are. It's just about within sight, isn't it?
How do you describe the benefits and see the potential of PAs changing once regulated?
I think the biggest thing will be just making it a profession that people accept as a real profession, if you see what I mean. Interestingly, and you won't know this, I don't suppose, being much younger than I, but a lot of professions did not used to be statutorily regulated. Physios weren't statutorily regulated until about 15 years ago. Mm-hmm. So when I was a junior doctor, I was working with all kinds of professions that were not under statutory regulation. I think they should have been. And I actually think anybody working face-to-face with patients, and that includes healthcare assistants, should be statutorily regulated. Because regulation, it seems to me, does two main things. No, more than two. Never say how many things are in a list till you get to the end of the list. It does some things. One of them is it provides that assurance that this is what we mean by this profession. These are its boundaries. This is how you train. This is how you get into it. So people know what this beast is. Secondly, it controls the quality of people who not only get in, but stay in. Being with the GMC, being regulated, gives you control of what the profession is, control of who's in the profession, both of which are for patient safety, basically. And of course, the GMC, the small p politics, if you like, of this is the GMC is the medical regulator. It's the doctor's regulator. So pulling the PAs into that regulation umbrella, that seems to me to have a lot of, if you like, soft power, soft weight behind it. It's not, any statutory regulator would give you the first two things that we talked about a second ago, but they wouldn't give you that. And I think that's been a great success for the profession. So I think it's going to go from strength to strength. It's currently growing at about 800 or so a year. It should be 1,000. 10 years from now, I think there'll be 10,000 PAs in the UK or thereabouts, which is quite exciting. I only live a mile from the local hospital. They have quite a few PAs. I'm in my mid to late 60s. So I'd be very happy for a PA to look after me, as long as they're nice to me and, don't go, oh, I've got Professor Parle under my needle here. Revenge time. Hopefully that won't happen.
And for listeners who are interested in GMC regulation, there's an episode with Claire Barton from the GMC who discusses a bit more about the process of regulation and what it might mean for us. If I ask you to look ahead as well as to career development and what you think PAs might be doing 10, 20 years down the line, how do you see a PA in primary care, a PA in hospital maturing and growing into new space?
I believe the American model is the correct model, which is the PA profession is not a ladder-shaped profession. Let's think about doctors, because one of the problems is people have this image that professional progression looks like doctors moving up the ladder. Mm-hmm. So from FY1 to FY2 to this, that, and all these different things. I say, okay, so you become a consultant or a GP at, let's say, 31. Where's your career progression now? You're going to be a consultant for 35 years. Where's your career progression? So we need to get away from this idea that there has to always be a way of moving up. What I think the future, if you like, more senior PAs, and I think we should be wary of making the mistake that I think the nursing profession made a long time ago, which is to get promotion, you move further away from patients.
Yep.
And actually, doctors have done pretty well with this, not falling into this trap. So it doesn't matter how senior a consultant you are, or how senior a medical academic you are, for that matter, you will almost certainly be seeing patients. You may not be seeing so many because you've got other responsibilities, but you still do the real, proper, face-to-face job that medicine is about. And I think it's really important that PAs hold on to that. So I would love to see PAs being promoted and moving up the ladder of salary and etc. There's a lot of doctors, and for that matter, specialist nurses, who get bored. After 25 years of doing aortic aneurysms, it's getting pretty damn boring. And I think for PAs to keep the idea of working in a specialty, but not being a specialist, that gives you the ability to change career. And a substantial proportion of American PAs, because that's the only one with any history, do change. They may stay. I think the mean a few years ago was 7 to 8 years in one specialty area. So to maintain flexibility. So I think the career progression is the career flexibility. To work in one area and then say, I want to do something completely different because I'm a bit bored, or my life circumstances have changed. Maybe they've got children, or the children have grown up, or I'm not going to bother with children, whatever the heck it is, doesn't really matter what it is. Or I want a portfolio career, and I want to do 2 days a week of A&E and 2 days a week of orthopedics, or whatever, or mental health, for goodness sake. You can do such completely different things. I think career progression is becoming better at what you do, becoming respected for what you do, and in my view, staying with the face-to-face work with patients, as well as having, if you like, a sideline of a PA ambassador comes randomly to mind, or a member of the faculty board, or whatever it may be, or an academic or a researcher. And in passing, I don't know if you know this, I'm hoping I think it's been in one of the blogs that Kate Stroughton writes. PAs can now access funding for PhDs as clinical academics, not with an already academic post, but actual clinicians in the NHS. That is very recent, and until only a few years ago, really only doctors could get those things. So there are ways to advance your career, vary your career, do different things.
That's really interesting and refreshing way to look at things. I think a lot of PAs that will resonate for a lot of PAs. There's so much research done into drugs, therapeutics, and what we do to patients. There's comparatively relatively very little about who does it to patients.
Yes.
So I think doing a PhD in PA studies would be really interesting.
Yeah, Jane, I think that's a really interesting point you make, and I thought about this a few times as well. Billions of pounds are spent on drugs, and that's to, take the vaccines, of course, many times that's fantastic.
Yeah.
Other times, actually just producing me too. I've got a better version of ibuprofen and I'm going to sell it to you. That's what actually most drug company work is, although they won't admit it. But so little is put into A, the workforce, and B, the education of the workforce. How can we make better doctors? Who's doing the research on that? How can we make better PAs or better nurses? Actually, you may or may not know, in nursing, a lot of courses have 2 or even 3 entries a year. So there's a continual flow of new nurses going into the system, whereas medicine, they all start at the same time and they all suddenly hit the wards in the killing month of August, the killing fields of August. And that's not really a good way to manage a workforce, to have a sudden influx of people. So having people coming out 2 or even 3 times a year actually is quite advantageous, I think. The other thing about employers was, because I spent a lot of time talking to employers in the early days, and for many years afterwards actually, was to say to employers, oh, well, you've missed the recruitment cycle for this year, come back in 12 months, was not really, they're going to say, oh, well, bugger that, we'll go and do something else.
Yeah, it's not the answer to their problem at the time, is it then?
Exactly, and they always want things to happen like now. Whereas if you said, well, come back in 4 months and there'll be another trench coming out, that was a very different perception from their point of view. There was quite a lot of concern when the program started to expand fairly fast, let's say 3 or 4 years ago, that we'd be producing too many PAs. But as far as I can tell, from what I understand, as long as you've got people who are willing to move, if you insist on training in Birmingham and staying in Birmingham, then that gets a bit more difficult. But if you're willing to be flexible, then the jobs are coming and they'll keep coming. The Health Education England are talking about wanting 1,000 PAs a year coming out within the next few years. I think they said by 2024 they want 1,000 qualifying, which probably means a recruitment of 1,200 or so per year, which is not where we're at the moment. So I'm not actually convinced we need more courses. I think what we need is courses to grow a bit, each of them grow a bit, and for them to be better resourced. But of course, at the moment, it's not a great time to be asking for extra resources.
Final question that I had to ask you, if that's all right, was any thoughts you had on the name? You mentioned right at the beginning of the profession that the course was called Medical
Care Practitioner.
And obviously it's changed. It changed to physician assistant. It changed from that to associate.
Yes.
Do you think the name will stick? Do you think it's a good name?
Okay. So the question of the name for PAs is an interesting one. I was involved in that early development of the MCP as a title, because we were trying to make sure it had medicine in it, but practitioner has a particular meaning in the NHS, and assistant also has a particular meaning in the NHS. Healthcare assistant is very much seen as an assistant, whereas when the profession had the vote to change the name again to associate, it was largely because of that issue that assistants don't prescribe, assistants don't make decisions, assistants are not true professionals, if you like. And so it didn't really work for me. And the reason physician assistant was in place was that when the competence and curriculum framework was sent out for consultation, the DH also consulted on the title and gave a couple of alternatives. And most people who commented voted for the physician assistant title because they said, well, if you type medical care practitioner into Google, you don't get anything. If you type physician assistant into Google, you get something and you can see what it means. I think that's less of an issue now because PAs have been around for a while. There's a couple of thousand of you. But I think physician associate gives a better flavor for what the role is. You're not there to assist the doctor. You're there to work alongside doctors and to work with doctors as part of a medical team. So associate, but once the title is fixed by the GMC, it will become the protected title. So it is quite important to get it right at the moment.
Does the term physician have specific weighting to you? I'm just thinking of PAs who end up going into surgery.
Surgery, etc. Yeah, I know. And that was one of the reasons we talked about it. And that's one of the reasons why we had medical care practitioner, because it was felt, well, what about surgery? Although, surgery is actually a fairly small part of medicine. If you look at medicine as a whole, there are more psychiatrists than any other specialty, more GPs than any specialty, any hospital specialty. Surgeons, although they have a big place in our minds and it's extremely important, is actually a fairly small proportion of medicine. I think actually the answer is to ask the public, get a few focus groups together and ask the public what they think. And so if you can come up with a better title, then great. I've recommended, and nobody's listened, but that's my life. That when doctors answer the phone, they say, "Hello, it's Dr. Parle. Hello, it's Dr. Smith." I think PAs should answer the phone. "Hello, I'm PA Parle," or "I'm PA Smith."
Yeah,
that's your title. I'm PA Jones. I'm PA Smith. Use the damn title, and then everybody will use it. But if you guys don't use it, then nobody will. And so you could be on a team for ages, and people say, "You've got a PA on your team." And say, "Oh, I don't know. We've got the guy called James. He's a PA. Is he a PA? Don't know. Is he? Because you don't use the title."
As we take this time to take stock of where the PA profession is at the moment during PA week, is there anything that you see physician associates not being able to do?
I'm going to interpret that as is there any area of medicine that physician associates might not be able to work in? And I think PAs can work everywhere. I really don't see any reason why they can't work in interventional radiology, in pediatric mental health. I mean, you name it, I think PAs can work there while maintaining that generalist contribution and that generalist. I kind of like to think of it like a visa or a passport that enables you to move between different specialty areas as one's career develops. I expect to see PAs in management. I expect to see PAs in research, in leadership roles. But I would want, because this is how you maintain your street cred. And, I think there are some doctors who don't do any clinical medicine at all, mostly in public health. But most medical academics and most medical managers continue to be medics as well. And I think that's extremely important. So I would see PAs being everywhere eventually and being the resilient members of the developing team. Because if you can maintain that generalism, and I personally think maintain the assessment to prove your generalism knowledge levels, that's your passport to be able to change, not only as your interest changes as an individual, but as the health services needs change. And, I've been qualified for 40 something years, and we do things now that nobody had even imagined then. And also there are things we used to do then that we thought were completely routine, and now they've completely disappeared. And nobody knows which of those things is which, what's going to disappear, what's going to be new. And the most flexible members of the team, if you think in evolutionary terms, are the ones that are going to survive. And PAs are the evolutionary. You're the stem cells, or you can turn yourself back into stem cells. So you can work anywhere, anytime. And I think if you can continue to get regulation right, that gives you opportunities abroad, working for NGOs and so on in other countries. The possibilities are infinite, I think. It's really important. I think for individuals, I think that's the problem with a lot of the young, relatively newly qualified PAs, which of course is by far the majority, don't have a concept of what 20 years or 30 years from now in the same profession will look like if they stay in the same place. But I can tell you from medicine and from nursing and from what I know of the American PA profession, the ability after 20 years in orthopedics to say, you know what, I quite fancy mental health now. Nobody else can do that. But to do that, you have to maintain your generalism. I think it's your ace in the hole.
That's fantastic. Well, Jim, it's been such a pleasure to talk to you today. Thank you for giving up the time. And I found it really interesting to hear your thoughts and where we've been and where we're going in the future.
Thanks for inviting me. I've enjoyed it.
Thanks to you for your help in setting up the profession in the UK. Phil Begg described yourself and him as the grandfathers of PAs in the UK.
Yeah. I think that's not bad. I prefer to think of myself as the obstetrician, but anyway.
Very good. But thank you. Thank you for what you've done to help establish us so far.
You're welcome. It's been fun most of the time.
Thanks for listening to the Physician Associate Podcast.